So with rosacea, there's obviously a few different subtypes of rosacea. So some patients can present with sort of erythrotelangiectatic rosacea, which is more redness or vessel change on the skin. And treatment or management of that can be quite different to, say, papulopustular rosacea. And then there's ocular rosacea, granulomatous rosacea, and neurogenic rosacea as well, where they get burning and stinging. So depending on how the patient presents and the types of rosacea they have is really about where we go for management of that. For papulopustular rosacea, which is one of the more common presenting complaints with rosacea, is we typically do good gentle skincare. That's very important because if we use any products that are a little bit harsh on the skin, particularly things like retinoids or AHAs, it can really trigger off the rosacea. For a lot of patients, sunlight is a trigger, and also spicy foods and alcohol as well. If we want to manage papulopustular rosacea and they've tried to get rid of all the potential triggers, we'll typically use some topical products, starting off with something like topical metronidazole gel or cream. And if that fails, we can use things like azelaic acid or topical ivermectin. In addition to this, we can use oral agents. So the first line oral agent, if it's safe to use, is doxycycline or then minocycline. However, you have to be careful with that because if the patient is female and potentially pregnant, we don't want to be using it. Or if they're breastfeeding, we don't need to use it as well. Then we have options of doing things like erythromycin orally. With treatment-resistant rosacea, in terms of other systemic therapies, we can use low-dose isotretinoin as well. If we're looking more at the erythrotelangiectatic rosacea, that's a little bit harder to manage because there's limited options. So there is a topical product out there called brimonidine gel, or Mavaso, that can be used to constrict the vessels and reduce redness. However, it's only transient and lasts for about 10 to 12 hours. And some patients, if they use it too frequently, can experience a rebound effect. So typically, I would only get patients to use that for more special occasions rather than on a daily basis. Obviously, for some people, camouflage can be used, so we can use tinted foundations, moisturizers, sunscreens to help cover up redness, and the green-based makeups are good to counteract redness as well. Further to that, we can use vascular laser. That's the most commonly formed treatment for erythrotelangiectatic rosacea. So any vascular laser can be used. We use an ND-YAG laser. There's lots of different vascular lasers that can be used, and that usually requires anywhere between 2 to 5 treatments to get good results. You can also pick up background erythema or redness with certain laser devices as well as track the vessels along. If patients are experiencing flushing with rosacea, there are a number of oral medications we can try for that as well, including oral propranolol and oral carvedilol. When patients have ocular rosacea, that's quite tricky to manage. We can use oral doxycycline, but sometimes referral to ophthalmology may be warranted in that setting. So in terms of the general sort of measures, gentle skincare is very important. So obviously there's a lot of product ranges out there, but some product ranges are specifically designed for rosacea prone skin. We often recommend products like Avène, La Roche-Posay, and Bioderma, specifically the rosacea-prone range products. There's a number of additive things that can be used as well to calm down the skin. So some antioxidants like zinc and B3 from a product like The Ordinary can be used as well. And then general good skincare in terms of not using anything harsh on the skin. So we don't want to use any physical or chemical exfoliators, and we want to not have too hot water, because if the water is too hot, it doesn't make the condition worse, but it makes it look worse. So if people get out of the shower, they often say, oh, the shower's made me worse, but actually the hot water has caused the vessels to dilate and make it look transiently more red, which will often settle down about half an hour later. In terms of GPs managing rosacea, they can use or manage most of the changes in rosacea, but I think if they're treatment resistant or flaring or not responding to, say, topical and oral medication, then that would be one reason to refer for potential use of something like oral isotretinoin as a low dose. And also if they have that erythrotelangiectatic change, because if they don't have access to a vascular laser, then that would be a good reason to refer on for such treatment.